Hey dear students, we are in the second part of restrictive lung diseases including pneumoconiosis. This is Dr. Shaima El-Gohari, lecturer of pathology. Occupational pulmonary diseases include coal worker, shipbuilding, electric switchboard formation, roofing isolation, cable sheath formation, pipe insulation, boiler insulation, cement asbestos pipes, breaks, all these works showing the pneumoconiosis disease. So we can change the name of pneumoconiosis into occupational lung diseases. All these type of works dealing with isolation material, isolation of the roof, isolation of the ships, isolation of the electric switchboards or cables, pipe isolation, and asbestos pipe formation. So pneumoconiosis, it is a non-neoplastic lung reaction to inhalation of organic or inorganic dusts, chemical fumes and vapors also. Okay, it is non-neoplastic, but some of these material can lead in the future to cancer like asbestos exposure. Okay, pneumoconiosis, the lung reaction depending on two parameters, the size of the particle and the reactivity of the material of the particles. Okay, the size, large particles are not reaching the distal airway, so no harm. The very small particles, less than 5 micron, will move into and out the alveoli, and get out with the secretions. Okay, what is the problem is that intermediate particle from 1 to 5 micron, it will be entrapped, enter deep into the distal air spaces and will not get rid of this. Okay, reactivity of the particle, either these particles are harmful or inert. Like coal dust is relatively inert, it will not form injury to the lung until it becomes very large amount of that material deposited into the lung before lung disease is clinically detected. But silica and asbestos are more reactive, resulting in fibrotic nodules at lower concentrations, not large amount like coal dust. Just low concentration of exposure to this material, asbestos and silica, lead to more reactive lesions in the lung. What is the pathogenesis of pneumoconiosis? The particle enter into the alveoli. Okay, these are the particles. These particles are engulfed by the macrophage. That cell is macrophage, which is in the alveoli and in the interstitial tissue. These macrophages will be activated, producing toxic factors as oxygen-free radicals, and will produce fibrogenic and pro-inflammatory factors like interleukin-1, tumor necrosis factor, and fibronectin. All these substances will form recruitment of the fibroblast and more collagen deposition. Okay, and also recruitment and activation of more inflammatory cells. These more inflammatory cells will produce more toxic factors like oxygen-free radicals, and the cycle will be more and more. The net result will leading to lung injury followed by fibrosis. Okay, like other chronic interstitial pulmonary fibrosis. Let's start with coal worker or carbon dust pneumoconiosis. Okay, in coal miners, managem. Coal worker or carbon dust pneumoconiosis, the reaction to coal dust ranges from asymptomatic anthracosis, just brownish pigment or blackish pigment detected in the lung accidentally, or simple coal worker pneumoconiosis, or complicated coal worker pneumoconiosis, which is called leading to what's called progressive massive fibrosis. Progressive massive fibrosis is a generic term not described only in the cool worker. Its fibrosing reaction massive in the lung can be detected in other types of pneumoconiosis. It is a massive form of fibrosis in pneumoconiosis called progressive massive fibrosis. Okay, let's start with asymptomatic anthracosis. Just carbon pigment accumulated in the lung. Accumulated where in the lung? In the alveolar macrophages, either in the alveoli or interstitial tissue, in the connective tissue surrounding lung alveoli, or in the lymphoid tissue along the bronchi and lung hilum and pleura. We can detect anthracosis in hilar lymph nodes, mediastinal lymph nodes, okay, and in severe cases we can detect it in the epigastric lymph nodes. The second form of cool worker pneumoconiosis is a simple cool worker pneumoconiosis. In this lesion, the molecules are 1 to 2 mm and there is nodules. These nodules formed of carbon-laden macrophages aggregated with surrounding little fibrosing reaction. Little, not much. Okay, occur in upper lobes, in the upper zone of the lower lobes, around the respiratory bronchioles, leading to what's called, as we studied before, centrilobular or centriacinar emphysema. Okay, cigarette smoking, centrilobular emphysema. Okay, cool worker pneumoconiosis, centrilobular emphysema. Okay, remember that type. Cool worker pneumoconiosis are either coal dust molecule or coal dust nodule. Coal dust molecule, aggregation of pigment-laden macrophages with little surrounding fibrosis. But the other form is large aggregates of pigment-laden macrophages with much more collagen forming a nodule. The third form of cool worker pneumoconiosis is the complicated form, which causes progressive massive fibrosis. That large area coalescence of nodules producing intensely plaque scar ranging from more than 2 cm and may reach up to 10 cm in diameter. Okay, these areas are due to central cavitation due to ischemic necrosis from the much more fibrosis. Cool worker pneumoconiosis leading to dense collagen deposition with blackish pigment. Clinical course of cool worker pneumoconiosis, early disease, little affection of the lung function, less than 10% of progressive massive fibrosis developing pulmonary hypertension. That's why, because hypoxia leads to reflex vasoconstriction, increased resistance against blood flow, also parenchymal destruction and fibrosis leading to destruction of the alveolar capillaries that become fewer, and this will increase the arterial resistance and resulting in pulmonary hypertension, and so leading to cor pulmonale, which meaning right side heart failure. Progressive massive fibrosis, once develops, it becomes progressive. Okay, even if further exposure to coal dust is prevented, okay, the lesion will develop and progress. No evidence that cool worker pneumoconiosis predisposed to TB like silicosis. Okay, no evidence that cool worker pneumoconiosis in absence of smoking lead to carcinogenesis. Okay, so cool dust is inert substance not leading to either increase in the incidence of TB infection or in the carcinogenesis into pulmonary carcinoma if it is not accompanied by smoking. Okay, silicosis. Silica is a particle in the sand and stone, so it affecting people working in sand cutting, stone cutting, and sand industries like glass industries. Okay, so silicosis can be inhaled, okay, causing inhalation of silica particle. occupation in stone cutting, tunneling, drilling, okay, chronic nodular silicosis, and complicated silicosis, which will lead to progressive massive fibrosis. Chronic or nodular silicosis is a prolonged time exposure to silica leading to fibrotic nodules in upper lobes of the lung, mostly subpleural. Okay. These silica particles, as it is part of the sand and stone cutting, can be accompanied by coal particle, some carbon particle or coal particle, and leading to that blackish color. Under microscopy, it is a concentrically arranged hyalinized collagen fibers surrounding an amorphous center. Okay, that whorly appearance of collagen fiber is distinctive for silicosis. Chronic or nodular silicosis. Silicotic nodules are concentric, whorly collagen fibers with inflammatory cells like lymphocytes and macrophages surrounding silica particles. Okay, sometimes the center of that nodule underwent central cavitation or softening due to presence of associated TB infection, as silicosis increases the incidence of TB infection, or due to ischemic necrosis of the central part of the nodule. Okay, that stain is called mesenterichrome stain, responsible for staining of collagen fibers. Chronic nodular silicosis, under microscope, under polarized light, there is that refractile silica particle seen in the center of the nodule, forming needle-like structures, like that one, needle. Okay. One of the complications of silicosis is increased risk of the affected patient to get infected by tuberculosis. That's why, because the inhibition of the ability of lung macrophages to kill and phagocytose the bacteria causing TB. Recently, crystalline silica is carcinogenic also due to release of oxygen-free radicals. So it's liable to increase susceptibility to get TB infection and to undergo carcinogenic effect due to release of that oxygen-free radical substance. Clinical course of silicosis: first, fine nodularity in early stage, then coalesce to form large nodule in later stages. These nodules are present in upper and middle lobes of the lung. Dyspnea develops late when there is a progressive massive fibrosis in the lung. Once progressive massive fibrosis occurs, as like that of the coal worker, that progression, it is a progressive course, even there is no more exposure to the silica particle. Okay, pulmonary hypertension may occur, that like in the coal worker pneumoconiosis, due to hypoxia leading to vasoconstriction. Yes, and the second cause due to destruction of the blood vessels and increased vascular permeability in the few remaining vessels. Okay, also cor pulmonale occur. Okay, what about increasing susceptibility to TB infection due to decreased killing activity of the macrophages, bacteria causing tuberculosis? Okay, some studies revealed that there is a relation between crystalline silica and lung cancer due to increased oxygen-free radical production. Asbestosis used in shipbuilding, electric switchboard, roof isolation, cable sheath, pipe insulation, boiler insulation, most of insulator. Asbestos-related diseases. Asbestosis is a crystalline hydrated silicated material that forms fibers. Exposure to asbestos is linked to much more diseases like localized or diffuse pleural fibrosis and pleural plaques with calcification, pleural effusion, fluid in the pleura, exudation of fluid, pleural mesothelioma and peritoneal mesothelioma. They are malignant tumor of the serous membranes. Malignant tumor. It is mesothelioma, but it is malignant, like lymphoma and melanoma. All of these are ending by oma, not sarcoma or carcinoma, but they are malignant forms of tumor. The first three lesions are pleural lesions. Okay, the two second lesions are lung affection. Okay, pleural lesions, and these are lung affection. Lung affection by parenchymal interstitial fibrosis by asbestosis and increasing incidence of lung carcinoma formation. Also laryngeal carcinoma or maybe extrapulmonary neoplasms increase the incidence in general of neoplasia, like cancer colon also. Asbestosis is characterized by diffuse interstitial fibrosis of the lung, beginning here in the lower lobes, not like the silicosis, okay? It beginning in the lower lobes around respiratory bronchioles and alveolar ducts, then it extends to the adjacent alveolar spaces or alveolar sacs. Notice that they are in lower. Asbestosis, usually cut section of the lung appear more fibrosis, like here that fibrous bands. Okay, the interstitial fibrosis affecting more in the lower lobe, markedly thickened pleura with pleural plaque. In asbestosis, the fibrous tissue distorts the air spaces and its contraction leads to honeycomb appearance of the lung due to enlargement of some destroyed air spaces with some thick fibrous wall within that enlarged spaces, leading to that honeycomb appearance. Okay, like here in that structure, some dilated air spaces and some markedly fibrotic interstitial tissue in between. X-ray of asbestosis revealed irregular linear densities at the lower lobes, together with multiple plaques affecting pleura with pleural fibrosis, areas of calcification forming eggshell-like density in the X-ray. Okay. Also, it may be present in silicosis. Asbestosis of the pleura may show fibrous thickening of the pleura with fibrosis of the visceral and parietal layers, fibrocalcific plaques on the parietal layer of the pleura, pleural effusion, and malignant mesothelioma or malignant tumor of the pleura, which is mesothelioma. Asbestos fibers are a golden brown structures, beaded rods, like that in that picture. Or again, this is asbestos particles. Okay, beaded. Clinical course of asbestosis including dyspnea and cough, which appears after 10 years of exposure, may remain static, or pulmonary hypertension and cor pulmonale may occur. Chest X-ray revealed irregular linear densities at the lower lobes. Later on, honeycomb appearance develops due to distortion of the respiratory bronchioles, alveolar duct, and alveoli with intervening fibrosis in the surrounding interstitial lung tissue. What is the pathogenesis of pneumoconiosis to summarize? In the case, I can say that there is a patient working in coal worker or sand blasting or shipyards. Shipyards يعني shipbuilder. Okay. Coal worker, coal worker pneumoconiosis. Sand blasting equal silicosis. Shipyards equal asbestosis. Okay. So the particle in each one is less reactive in coal worker pneumoconiosis. It's inert. More reactive in silicosis and asbestosis. The affected lobe in coal worker and silicosis are upper lobes. Okay. However, in asbestosis, more affection in lower lobes. Grossly, Co-worker forming nodules, silicosis forming nodules, however asbestosis forming linear streaks. Under the microscope, co-worker starting with macules progress into more large nodules up to massive fibrosis with plaque pigments and central breakdown due to central ischemic necrosis. The rest of lung tissue may show centri-acinar emphysema. Okay, in silicosis, silicotic whorly nodules surrounded by collagen and inflammatory cells, okay, may be detected. In asbestosis, there is fibrosis and inflammatory cell infiltrate surrounding asbestos particles with honeycomb appearance in the radiology. Complications of co-worker pneumoconiosis include progressive massive fibrosis, which may be detected in each one of the pneumoconiosis types. Okay, cor pulmonale also may be detected in the whole 3 types. Okay. Plus, in silicosis, we can add TB, and recently it may be carcinogenic. In asbestosis, there is a pleural complications, pulmonary complications, and extrapulmonary carcinogenesis like cancer larynx and cancer colon. Okay. Regarding pleural complication, pleural fibrosis, effusion, fibrocalcific plaques, and malignant mesothelioma, it is a malignant tumor of the pleura. Okay. In lung complication, increased incidence of bronchogenic carcinomas, okay, and lung fibrosis leading to cor pulmonale and pulmonary hypertension, okay. Also, extra pulmonary carcinogenesis may occur, as we said before. By this, we completed the restrictive pulmonary diseases. Thank you and good luck.